Welcome back to Medical Review with Dr. H. Today, we are diving into a topic that can feel, well, just overwhelmingly complex: pericardial diseases. Now, you could spend forever memorizing every single cause, but we're going to take a much smarter approach.
And this, right here, is the secret sauce. We're going to focus on how the pericardium, that little sac around the heart, actually reacts when it's under attack. You see, understanding its response is the key that unlocks everything else.
So here's our game plan for today. We'll start by laying out our core framework. Then we'll explore the pericardium's three main responses: inflammation, what happens when hemodynamics go haywire, and what happens when you get anatomic scarring. Then we'll wrap it all up with a quick summary and a case challenge to really put your knowledge to the test.
Okay, let's jump right into this new way of thinking. Instead of getting totally bogged down in a laundry list of causes, viruses, trauma, cancer, and so on, we're going to organize these diseases by what they are actually doing to the body.
And really, it all boils down to these three things. First, the pericardium can get inflamed. We call that pericarditis. Second, fluid can build up and start squeezing the heart, causing what we call hemodynamic compromise. And third, if that inflammation sticks around, it can lead to permanent scarring, which is a straight-up anatomic problem. That's our roadmap. Simple, right?
All right, let's kick things off with that first response: inflammation. When the pericardial sac itself gets angry and inflamed, we give it the name pericarditis.
You know, that itis suffix is always a dead giveaway for inflammation. And when this sac is inflamed, it rubs against the heart with every single beat, and that causes a really distinct kind of chest pain. It's pleuritic, so it gets worse with a deep breath, and it's positional. Patients will tell you it feels a lot better when they lean forward and way worse when they try to lie flat. Now, there are a bunch of things that can cause this, but for day-to-day management, there are really only two you need to keep at the front of your mind: viral infections, which are by far the most common, and uremia from kidney failure. And you'll see why that distinction is so important in just a minute. And here we go. This is a massive, high-yield point for your exams and for the real world. You suspect pericarditis. What's the very first test you order?
The answer is an EKG, not an echo. Look, an echocardiogram is amazing for seeing fluid and structure, but it can't see information. The EKG, though, it picks up the electrical chaos that inflammation causes. What you're looking for are these diffuse ST segment elevations pretty much everywhere, and the real giveaway sign, the pathognomic sign, is PR segment depression.
So it makes sense, right? If the problem is inflammation, the treatment is anti-inflammatories. And the gold standard here is a 1-2 punch of NSAIDs for the acute inflammation plus colchicine. Now, why the colchicine? Because it is absolutely fantastic at preventing the pericarditis from coming back. And here is the classic trap you have to avoid. Don't immediately reach for the steroids. Yes, they're powerful anti-inflammatories, but for some reason they actually make it more likely that the pericarditis will recur, especially if it was caused by a virus. You save them for when you have absolutely no other choice. But of course, there are always special cases. You can't just give NSAIDs to someone with kidney disease or a bleeding risk. And with colchicine, you gotta watch out for diarrhea. That's its main side effect. And hey, remember that uremic cause we mentioned? Well, if kidney failure is the root problem, no pill is gonna fix it. The treatment is dialysis. You have to clean the blood.
All right, let's move on to our second category. So what happens when that inflammation leads to fluid building up around the heart, and that fluid starts to physically squeeze it? Well, now we have a hemodynamic problem.
You can really see how everything just shifts here. With pericarditis, the problem was inflammation, and the symptom was chest pain. With a pericardial effusion, the problem is fluid buildup, and the main symptom becomes shortness of breath. And because now we're looking for fluid, guess what? The echocardiogram is finally the right test to use.
Now, if that fluid builds up way too fast or just way too much, you can get a true life-threatening emergency called cardiac tamponade. The pressure gets so high that it literally crushes the heart, especially that weaker right ventricle, and stops blood from even getting in.
Tamponade is something you diagnose at the bedside, and you're looking for Beck's Triad. You'll see jugular venous distension, JVD, because the blood is backing up. You'll see hypotension because blood can't get out, and you'll hear muffled heart sounds because all that fluid is in the way. But here's the absolute key clue. Their lungs will be crystal clear. Why? Because the blood can't even get through the crushed right side of the heart to get to the lungs to cause congestion.
Okay, this is a code-level emergency, and you have to act fast. The very first thing you can do is slam them with a bolus of IV fluids. It's a temporary fix that can raise the pressure just enough to force that ventricle open. But the definitive treatment? That's a pericardiocentesis. You have to get a needle into that sac and drain that fluid right now.
Okay, finally, let's talk about our third response. What's the long-term story here? What happens if you get inflammation over and over again for years? Well, that pericardium can become scarred, fibrotic, and totally rigid. This isn't an inflammation or a fluid problem anymore. It's a structural anatomic problem.
We call this constrictive pericarditis. The pericardium literally turns into a stiff, unyielding box around the heart. Now, the heart can squeeze just fine to pump blood out. That's systole. But it can't relax and expand to fill up with blood. That's diastole. And that leads to all the classic symptoms of diastolic heart failure.
And this just illustrates our core concept so perfectly. Because this is an anatomic problem, medical therapy, pills, is going to fail. You need an anatomic solution. The only cure is a pericardiectomy, where a surgeon literally goes in and cuts away that scarred, constricting shell.
So let's put this all together. The whole key is to figure out which response the pericardium is having. Is it inflammatory, hemodynamic, or anatomic? And then match it to the right intervention. All right, you ready? Let's test what you've learned with a quick case.
This table really brings our entire framework home, so let's just run through this one more time to lock it in. For pericarditis, an inflammatory problem, we use anti-inflammatories, NSAIDs and colchicine. For a stubborn, recurrent fluid problem, the answer is a pericardial window. For tamponade, a true hemodynamic emergency, we drain it with a needle, a pericardiocentesis. And finally, for constrictive pericarditis, an anatomic problem, the only solution is surgery, a pericardiectomy.
Okay, here's our case. A 28-year-old guy comes in with sharp chest pain. It feels better when he leans forward. He had the flu about 2 weeks ago. His EKG shows those classic diffuse ST elevations. What's the best initial treatment? Is it A, prednisone, B, NSAIDs plus colchicine, or C, dialysis? Think about it.
The answer is B. This is a textbook absolute classic case of viral pericarditis. We treat the inflammation with NSAIDs, and we add colchicine to keep it from coming back. We avoid the prednisone because we don't want it to recur, and dialysis is only for patients with uremia. See? By focusing on the pericardium's response, you can cut right through the noise and pick the right answer, every single time. And that's our deep dive. If you found this helpful, make sure you subscribe for more high-yield reviews. I'll see you in the next one.